A very good evening to you, and thank you very much for tuning into Metropole TV. If you're just joining us, we're in part 2 of Metropole Debrief, and when we sit down, it's time for the conversation. However, just to welcome you into the conversation and tell you today we're talking about the Kenya Cancer Scourge, what could be causing this and how do we move forward. Those of us who cannot catch us on the television sets, we are broadcasting live on Facebook, on our official Facebook page at Metropole TV, and also on our YouTube page at Metropole TV. Thank you very much, ladies, for joining me. Honorable Gladys Wanga, Women Representative, Homa Bay County, and Dr. Catherine Nyongesa, founder, Texas Cancer Center. Gladys, let me begin with you. You have a very interesting bill that you're presenting and you'd like amendments to be done. However, let's start. What exactly is the bill and what amendments are you seeking to introduce?
Thank you, and thank you for having me here at Metropole. It's my first time.
Yeah.
And I think it's a good job that you're doing in terms of the information that we're giving to the public. The Cancer Prevention and Control Amendment Bill was introduced by myself, actually, in the last Parliament. But I think in the last Parliament it came a bit too late, and so when it was up for second reading, we were unable to pass it before the Parliament lapsed. As you know, government bills take priority over private members' bills. Private members' bills are discussed one session in a week, including motions, yet while government bills are discussed every other Parliament session. So the Cancer Prevention and Control Amendment Bill seeks to do a couple of things, and the first is I examine the role of the National Cancer Institute, and with a view of adding more responsibilities to the National Cancer Institute. You know, we give quite a bit of statistics in the first section of the show, and I was just looking at them and wondering whether that is all, you know, or whether we're really reporting as much of the cancer deaths as they should be. Because when I go to Homa Bay, for example, every single weekend, you will find deaths from cancer, one form of cancer or the other. Many times they're being treated for other diseases, maybe pneumonia, maybe whatever else it is. I'm just wondering if as much reporting is happening. And one of the key roles of the National Cancer Institute is really focusing on research, but also just data collection and reporting so that we know what we are dealing with and what magnitude it is. So the amendment there is to give them the role of coordinating training of more oncologists with support of the government. And Dr. is here, and I guess she'll agree with me that there are too few oncologists, too few oncology nurses, oncology radiologists, too few in this country. And even the level of skill sometimes is a problem. And I said this, that before I introduced my bill, and when I went through cancer treatment in 2014, I went through treatment here and I went through treatment out of the country, and you couldn't compare really, because not just that not just about the facilities, but about the level of skill of our you know,
medical personnel.
Yeah, and especially the nurses, because I compared. I think the nurses here are used to just regular nursing. Probably we don't have as many specialized. So the doctors are too overburdened doing nursing duties, you know, because when I went to the hospital, I had to, you know, the nurse was trying, you know, the nurse is trying to find the port and the place to, and the nurse can't find it. So they keep pricking and removing, pricking and removing. Then they wait for the doctor. Now the doctor is too busy, you know, because she has to go here. But when she comes, instead of just finding everything set, she has to now start with other things that I saw out of the country were basic, you know, things that junior nurses were doing, and if they couldn't manage, senior nurses were doing. So one of the amendments that I'm making is to give the responsibility and funding to the National Cancer Institute to be able to give scholarships, government scholarships for training for our you know, general practitioners into oncologists, but also other cadres of workers. But the second and more important, and you know, I'll just finish it briefly, is to make cancer a part of primary health care. And of course the training is important, but also just recognize cancer as a part of our primary health care. So that's the other amendment that we're making to the original Act of 2012.
Thank you very much. Very pertinent issues you've raised. And Dr. Wata, you're here, and you're an oncologist yourself. You've practiced with Kenyatta National Hospital, and you have your own private practice. What is the situation on the ground? Let's start with Kenyatta National Hospital, because it's a public institution and it's the place that most people go to. From an oncologist point of view, how does the situation look like in the hospitals?
I would say there has been improvement in the past 5 years. You know, there was a time when our patients could wait for 2 years on the queue to get onto radiotherapy. But now, good news is that they are waiting for a month or less. So there's progress, but I'm sure more needs to be done, because as a cancer patient, no one would like to wait for a month or even 2 weeks. They want to get treatment as soon as possible. And waiting is also not good, because the cancer continues increasing. Also looking on the ground, I've seen the National Hospital Insurance Fund has come in to assist these patients in the financial burden. And at Kenyatta Hospital, patients are getting treatment using the card, and this has really gone a long way. When patients could stay away trying to fundraise, they no longer do that. Once their card has matured, it pays for the surgery, it pays for chemotherapy, and even for radiotherapy. And the National Hospital Insurance scheme has also gone beyond to try and bridge the gap by making patients access treatment even in private hospitals like Texas Cancer Center, Nairobi Hospital, Aga Khan, Mpisha. So in private hospital, I think you may have to co-pay something on top of what the card offers.
Hold on to that thought. Today, during the Requiem Mass of Honorable Joyce Laboso, the Deputy President spoke on the National Health Insurance Fund and what it was doing to help cancer patients. Let's listen in, and then we can pick it up from there.
15, because of the prevalence of cancer and diabetes, we did two things. Number one, we expanded the NHIF coverage, which originally did not cover cancer and diabetes, to include cancer and diabetes, so that more people can access treatment on NHIF. And as a result of that program, already 100,000 people have benefited from treatment under the NHIF oncology program.
By the government, Dr. Wata, but what more can be done to just ensure that cancer patients are able to get the treatment that they deserve?
One, we see that the cancer cases are increasing every year. So I think the public hospitals need maybe to step up through the assistance of the government, once funds are available, to build more cancer centers, to reduce the way patients have to travel all the way to Nairobi to get radiotherapy, for example. Also the NHIF to expand the oncology package, because at the moment it's limited to maybe 6 sessions of chemotherapy and 20 sessions of radiotherapy surgery. So it is good if this coverage can be expanded to be more comprehensive, even if the members of the public have to pay a little more. And then another thing is to train more healthcare personnel in cancer. And this cuts across. We have doctors, as Gladys said, nurses, we have therapists, counselors, palliative care team. So it's a whole lot of team, medical physicists. So that needs to be expanded. And at least for the first time in history, I think in the past 5 years, we could only talk of less than 10 oncologists. But now we are talking of 35 oncologists, which is a big step in the right direction, and we have 20 oncologists in training, and this is being done locally. University of Nairobi, Moi Teaching and Moi University in Eldoret, they have rolled out oncology training. but we still need more and more just to take care of this. And more so, we need to go to the grassroots level and try to create more awareness about the most common cancers, and so that we pick cancer early before it progresses to a stage that is not manageable. Because if we look at the statistics you are portraying, we are losing about 70% of all the cancer cases that are diagnosed every year. And this is not a unique problem to Kenya alone. It is actually across Africa. In fact, in total in Africa, the incidence rate to mortality is 65%. Kenya as a country, we are about at 70%. So it is a global problem, and it's a public health care problem that we need to take more serious interest and bust the myths about cancer and tell people what are the common cancers, which cancers can be screened for, and lifestyle change, and people just to avoid staying at home with illnesses that are bothering them, but they don't go to hospital. You know, so many people, you go to the village, you find they familiar a lot, and by the time the cancer is diagnosed, it's a bit too late.
I am seeing Honorable Wanga jotting down her notes. So let's pick up some rejoinders you'd like to pick up. Let's begin from, she says, we are training locally, we are 35 oncologists, but 35 to the rate at which people need Medicare. Does it make sense, or do we need to do more?
I think it doesn't make sense. Well, we've improved, but we are far from what we need to have. I think we imagine 35 oncologists, imagine all the cases of cancer at KNH, but not just KNH, the Homa Bay County Referral Hospital, Marsabit County Referral Hospital, all those cases. And if you go to Homa Bay, you probably won't find an oncologist. And therefore, nobody will tell you if you have cancer early enough. They'll probably refer you to Kisii, and Kisii, there's a long queue and so on. We have to do more. And that's why, as you know, before this bill came into being that I have proposed, I had a motion, and the motion was saying, could we train a doctor per county every year, sponsor the doctor, and I like what Daktari has said about the whole range of medical personnel, because sometimes we think it's just doctors, but if the other medical personnel also are not there, then the doctors are overburdened and they are unable to deliver. Can we just train one every year? Just give them scholarships, tell them you will be paid, but then you will go to University of Nairobi, or you'll go to Moi in Eldoret, or wherever, and you will be trained, and government will pay for you, but pay your salary at the same time. But then when you finish, you have to come back to your county referral hospital where you were, as a way of paying back that scholarship. And that's what I'm trying to do with the amendment bill, so that the National Cancer Institute has the power and the fund to be able to fund some of this scholarships. So it's too, I think it's a bit too modest, that number. Then there is the whole issue of NHIF and the cost of treatment for cancer.
Yes.
I think cancer, apart from just the fact that it kills, it is economically devastating for our people. Because what happens is, there's always the hope that, you're going to be better, So the people will sell everything they have. They'll be told, in Busia or wherever they are, you have to go to Kenyatta. Oh, okay, let's sell this, our 2 cows. We will take you to Kenyatta. Then they'll come to Kenyatta and say, oh, radiotherapy is this much per session. Oh, so now let's sell the other sheep. Oh, you'll be better. Then they sell everything. They sell everything. If the household had a car, if they have even household items, they have gone to all their friends, all the politicians they know, then the person passes on. The family has not just lost that person. The family has lost everything that they ever had. So it is an economic catastrophe. And that is why I'm happy that Daktari has said NHIF, has come in to cover cancer. I think that's a good step. We must appreciate that. But then, what is the NHIF covering vis-a-vis the cost of care, the cost of treatment for cancer? You gave some figures up there. I think NHIF, the sessions that they cover, or if you're going out of the country, they give you 500. They give you 500,000 shillings, but 500,000 shillings is really peanuts when it comes to treatment of cancer. So we must look at a way of expanding NHIF for some of these illnesses. So we'll have to look for a balance. As legislators, I think it falls on our tray to sit down with NHIF, structure up something. I think we had an increase in amount that people are paying for NHIF. We've had an increase in benefits, but then I think we can do better in terms of structuring that. But also, what I wanted to agree with, what I was noting down and I wanted to agree with, is the issue of public awareness. Whether our people really know what to look out for. I think, you know, when HIV started to become a problem, there was a lot of public awareness. And so people became very, very aware of how to prevent it, how it is caused, and so on and so forth. So I think we have to go to a point where the Ministry of Health and counties must have a campaign around awareness, and even us leaders and all of us, wherever you go, like right now, wherever you go, whenever you go, even if to a funeral or a public baraza, you're always talking about people getting opportunity to get screened. And then there is the issue of our health-seeking behavior. Sometimes because of, you know, poverty levels, people are just scratching through. People are just scratching through. If I go to the market and sell my wares, which are worth 500 shillings in total, I make a total of 150 shillings on top. All I can do really is to just buy omena, flour, cooking oil, all of them in small quantities, and go home and feed my children. Now, if I was feeling some pain on my side here, and it can still allow me to walk, I will just keep walking until the day the pain becomes unbearable. Yeah. That's when I'll say, oh, maybe I need to go to the hospital. And I think the health-seeking behavior is worse among men, even compared to women, because I think the men just want to be macho and strong and you know, go on their daily business, and they hate hospitals, and you know, they hate facilities. Women have to go and deliver. Maybe when they're delivering, something will be discovered, and so on and so forth, or take their children, and therefore, you know, they're a bit more. So I think the health-seeking behavior is part of the awareness that should be raised. But we need to now really, really talk to our publics, not just here in Nairobi, but in the villages about, and you know, and places like Homa Bay are better, you know, than places far north, maybe, where, you know, to get to the next facility, you probably have to get really long distances. Okay.
Speaking of the people, one of our reporters went out to the field and had a conversation with Kenyans on the streets and what they think about cancer. If they've had an experience with cancer, how much did it cost? How did they raise the funds to cater for the treatment? This is some of the issues we've just touched on the conversation, and we'd like to bring you into this conversation. Take a look.
Watu wengi ambaye nakunyeka cancer.
My auntie just passed away.
We have seen even prominent people who have suffered from cancer, and many of them dying.
I have a friend who she's a survivor. Even in my family.
Poor Kenyans. They are poor, don't go to big hospitals.
A family friend.
Sina mtu yangu wa karibu akona hiyo, lakini nasikia tu watu wako na cancer. Nimeona cancer, throat cancer, nimeona kusika mala, na hii ingine inaitwa bone marrow.
Colon and skin. She had throat cancer, breast cancer.
Saiti ile cancer ambaye inaenea kwetu, ile ya kusika wa mama tumbo, sehemu sasiri, sehemu ya usasi.
The treatment was done in Kenya, and she was admitted at Kenyatta Hospital.
It was in Kenya. We struggled, then they passed on. They are normal because we couldn't even afford to take them to India or elsewhere. My Guka had his surgery done in Kenya, and also the family friend is still undergoing treatment in Kenya.
It was very hectic to get treatment for her, since we tried all means, the NHIF, but it was not enough. So at some point we had to call for a contribution from well-wishers and neighbors.
Mambo ya NHIF ilikuja juzi, lakini samani tunafanya mchango nauza ng'ombe yako, nauza shamba yako, ndio ujitibu naye.
For her, she has a medical cover, but it's a bit expensive, so it's taking a toll over her. The first 2 sessions, it was catered for by the insurance, but now she has to sort herself out now.
But you know, in village, you can't make a big money from the Harambee.
Used the NHIF card.
Hii serikali inafaa kuleta hizo mashini, mtu anaangalia kila mahali. Kama na ukimwi walileta na kila mtu anajiangalia kila mahali. Mbona wasilete ya kansa kupima kila wakati?
Kenyans, come out in your large numbers and speak out of cancer. If you can't speak out, you know our leaders sometimes they just leave us to go and just die at home. So kila mtu Mkenya ajipambane na hali yake.
Well, very sad sentiments. Kila mtu apambane na hali yake. Let's start from treatment. The state of treatment in the country. It seems like those who cannot afford treatment abroad are the people that are treated here. What lessons can we borrow from India, the UK, places that have made advancements in treating cancer, and maybe Australia, Dr. Wata?
Okay, developed countries, the success rate is about 50%, so they are doing well. But one is also the economic muscle. They have invested heavily in the healthcare. The employment level is very high, so most people have access to a good insurance. Unfortunately, in Africa, the employment rate is very low and very few people have access to insurance. Even NHIF, out of a population of 40 to 50 million, only 5 million are insured, and we hope this is going to increase. So still there are many Kenyans out there who do not have any form of insurance, and those are the ones who are struggling to sell their property to get treatment. But in terms of how ready are we for treatment, I think the country has made a lot of strides also in the past 5 years. We have radiotherapy machines at Kenyatta National Hospital and many other in the private sector. The only unfortunate thing is that most of these resources are limited to Nairobi. So the people in the other counties have to travel, and this is really a burden, and you find not all patients with cancer are actually coming to Nairobi. In fact, out of the 47,000 new cancer cases, say at KNH we see about 5,000. So where are the rest? Where are the rest going? So they don't have good access to treatment. So we are hoping in the future that the government puts designated cancer centers, not every county, but at least as an immediate solution is to designate big counties where patients can go and access specialized treatment. And also we have what we call the National Cancer Treatment Guidelines, which stipulates what can be done at the lower level hospital. So long as those hospitals can be equipped with both cancer screening and cancer treatment equipment, we'll find things like surgery will be done at the lower level, chemotherapy may be done at the lower level, and then only patients who need specialized treatment or complex treatment will be referred to the big national referral hospitals like KNH or Moi Teaching and Referral. And then there is those who can afford a free to seek treatment anywhere in the continent. But even those who may not afford to travel overseas, majority of the cancer cases can be managed locally. Say surgery can be done locally, chemotherapy can be done locally, radiation can be done locally, though there's a waiting list for radiotherapy. But more needs to be done.
Honorable Gladys Wanga, your reactions on the video we've just watched, and maybe what you've picked from Dr. Wata's sentiments.
Well, I think the video is probably some of the sentiments there also reflect some of the things I'd said earlier around the economic catastrophe and people just sometimes feeling helpless, but also people, you know, having gotten treatment through NHIF and so on. But you can see the cost of care, the issue of the cost of care really coming out, because they're saying, oh, she's used her insurance and now she's unable to use any more. The issue of India, some of my friends would want to visit Governor Laboso in India, and may God really rest her soul in peace. They said they were meeting Kenyans in India, and this for me was very sad, who had just gone. You know, they had just went. They didn't even know which hospital or wherever. They just said, we are taking our patient to India, and now they were just walking there. Some of them were now being returned home because they could no longer pay for what was there. And so Kenyans are just in shambles in India. What are Kenyans doing in India in their numbers when they don't even know where they're going, you know? So it shows a breakdown of our healthcare system here, especially as far as cancer is concerned. You know, what India can do, Kenya can do. You know, just with, because India is also a friendly country. Can we just not have a partnership, you know, so that they help us, you know, in terms of training, in terms of equipment, in terms of all the things they're doing, Kenyans can actually get with care. Because one of the things I was even saying at the memorial of Honorable Ken Okoth today, and that's a brilliant guy we've lost there, and you know, may God rest his soul in eternal peace. I was saying, what kills people even more faster than cancer itself is the stress, you know, just the stress, just the fact that, oh, I have cancer, how will I ever get treatment? I don't have a thing, and so on and so forth. So if you're home and your family is around you, it's probably a better situation than if you're away, maybe with just one caregiver, and who's probably also now drained and overburdened. But here people can visit you and so on and encourage you. Your pastors can pray with you, your sisters, your brothers, and everybody. So the other thing I wanted to point out too is of course the fact that if you go to places that like the UK, they have a working, even if they complain, but if you come from here, you can just see that it's a working National Health Service, you know, where people just walk in, get treated, you know, and go. The citizens of the UK, you know, you just walk in, you know, and you go. And the public facilities, when I went out for treatment, the hospital was just a public hospital, but it's like better than a private hospital here because of the quality of care, attention to detail. You know, some of the things that kill people even is not just is just things gone wrong. You know, somebody was doing a surgery, even just a cesarean, they've left something in there. You know, just the seriousness of our medical personnel sometimes. I think, and Dr. can also comment on this, because some of our medical personnel sometimes have just become, you know, sloppy and careless, and you know, and not taking, and the systems also don't encourage them to take as much care. But you can also see that we now have a problem of healthcare personnel management after devolution of health. Each county is doing their own thing, and that's why one of the things we are proposing, and this we are proposing as embrace to the Building Bridges initiative, is to have a health services commission, so that doctors, you know, healthcare providers are managed nationally, centrally, just like the Teacher Services Commission manages the teachers, so that every county is standard. We know what people are doing. We are not dealing with one county has fired all its doctors. Now you're fired. How are you going to give treatment? And then lastly, is a bill that we are introducing in partnership with Honorable Sabina Chege. It's the National Health Referral Facilities Bill of 2019. What we're saying in that bill, and it refers to what Dr. was saying about facilities in the various areas and just equipping and strengthening them, is right now we're saying we have Moi Teaching and Referral Hospital, Kenyatta National Hospital, and maybe Mathare, and the spinal injury, when we're talking about national referral hospitals, you know. But there's a gap in the sense that people don't have to leave Homa Bay to come way up here. So what the bill is trying to do is to create national referral facilities in each county, so that the level 5 facility or the level 4 facility is upgraded to become a national referral facility. What that means is the money that goes to level 5 facilities, right now there's a grant, there's a conditional grant that goes to all level 5 facilities. That money only goes to maybe Kisii, Nyeri, you know, the 14 or so counties that have the level 5 facilities, but this is money that should go to all counties. So if we make the county referral hospitals, bring them to level 5, then the money, the grants can go directly to them. And then the money that goes to the hospitals also, instead of the money going to the county with the hope that the county will give it to the hospital, money should leave the national government and go straight to the hospital. Because part of the reason we're having a problem is money goes to the county doesn't give money to the hospital. And then now the hospitals are left starving. And even the money that the hospitals raise, they have to give it to the county, and then the county releases it back to them. It doesn't make sense.
Okay. Dr. Wata, 30 seconds, a brief rejoinder. She mentioned that there's a breakdown in the health system, particularly in the way medical care is administered from the medical practitioner. And we've seen this not just with other cases, but today, because we're speaking about cancer, we've seen cases of misdiagnosis. Is it negligence, or they just do not know?
Okay, in every system there are bad apples. And otherwise, in terms of misdiagnosis or late diagnosis, it's just that cancer does not come announcing itself. And most of the time, patients come to hospital with very vague symptoms. They say you have colon cancer. You'll come with constipation, gas in the stomach, or sometimes diarrhea. And these are very common symptoms. And people will go, they'll be treated for amoeba or typhoid. And then you go home, but the symptoms persist. And then our people, you know, they will say, I went to hospital, I was given some medicine, so I've not gotten better, but they decide to stay away. So we're encouraging members of the public that they also play a role in getting the correct diagnosis.
However, how do we hold our doctors to a higher level of account?
I think when a patient, if you've treated a patient who doesn't get better, they need to seek a second opinion.
Okay.
We also need to encourage our doctors to have what we call multidisciplinary teams. You know, you meet together different disciplines and just discuss a case. That will help. If there's something you've missed on the patient, your colleague will tell you, but I think here let's do like this. And patients who pass through multidisciplinary committees are managed much better.
Honorable Gladys Wanga, the bill you're introducing with Sabina Chege, brilliant bill. Even the bill that you're proposing amendments to, brilliant bill. However, it trickles down to the question of funding and finance. Currently, there's a lockdown of revenue allocation between the national government and the county governments, and governors have come forth and said it's the people that are suffering. Ego wars, government, national, county, you can fight all the more you want, but the person suffering is the person at the grassroots level. The Abuja declaration, governments agreed they'll allocate 15% to health. Currently, the national government allocates about 6% to health, and the county is 3.6%. If we are to deal with cancer and deal with it the right way, how do we go about financing?
Yeah, I think that's an important question. And just before I go to it, the issue of the multidisciplinary teams, I think it's really, really important, because no man is, you know, a monopoly of knowledge. So if people share ideas, then that's what then you find facilities where there's only one doctor, you know. You are the only one. Your word is law. Everyone is looking up to you. And that's why part of what my bill also deals with, and also my bill dealt with in the last parliament, but since then the Health Act has been enacted and deals thoroughly with the issue of e-medicine, so that people can and telemedicine, so that people can doctors can consult each other. There probably can be created a portal where I can just, if I was, you know, a doctor and I'm in maybe Garissa somewhere, I just upload, these are the scans, this is and then somebody else can input and tell me, look, I think you should do this, or refer the patient for this. And that can really help us also sort out the issue of our shortages and so on. But then on the issue of health financing, I think it's about our priorities and how we deal with corruption. Because even if you look at the issue of this leased equipment, you know.
Yes.
There's a big, you know, the things are just, even the governors came and said, what? You're leasing us equipment which we don't even have people who can operate. Now, we are paying for equipment,
yes.
But then they are sitting here because there was a, you know, even there was a radiotherapy, I think, machine that was brought to Homa Bay. No, there's no trained radiologists, so people are, they just, wanaota machine kama moto. Yeah, you know,
is this the reality though on the ground? And
yeah,
does the national government know this?
You know, this is the reality on the ground. And that's why even governors came and said this time they were not allocating money to that leasing of equipment. Because somebody sat somewhere and then they had their friends maybe and they said, let's do business. So the issue of corruption, and I must thank the president for the serious, you know, steps he has taken on this matter, because it has a very direct correlation to how, whether we finance our healthcare or we don't.
Yeah.
Because if we're losing a lot of money to projects are being inflated, you know, people are just putting, look, now we're dealing with the project was supposed to be 40 billion, the 2 dams,
yeah.
Then they went to 60 billion, and it's not just the dams alone. Every project you see, you're probably looking at double the price, 200%, 300% of what it is supposed to cost. So if we can deal effectively with the issue of corruption, then we can find money to channel to our healthcare. And if we are purposive, and some of the bills we are introducing, they might not look like they're going to direct money, but once they pass, if we pass and we say, if this bill like the National Health Referral Facilities passes and we are able to convert our facilities into level 5, then it means money will go to them. The money will have to come from the national government going to those facilities. That will be a good thing we will have done. If we set up cancer centers, that will be money put in the right place, but we must deal with corruption to be able to finance our healthcare.
Dr. Wacha, briefly, your thoughts on that, and then also kind of a contrast or compare-contrast of public health where you've worked and private care where you also partake.
I think both the public and the private, they complement each other. They are all serving Kenyans. But we really need to strengthen our public sector because that's where the masses go to.
Okay.
And the common mwananchi goes to the public hospital, and it has to be as good as the private centers. In terms of how do we build capacity in the county referral hospital, we've seen we have fewer oncologists than what we need. So which means the doctors in the national hospitals can actually go out and transfer skills to those in the counties. Show them how do we do chemotherapy, simple things, manage pain. A patient doesn't have to come all the way to Nairobi for pain control. If it is chemotherapy they are doing every 2 weeks or 3 weeks, can these protocols be disseminated? Just the way, you know, our patients will go to India and they have a protocol. You're not going to stay in India for 6-8 months. So they usually come back home with their protocols. This is written down, you should give like this. And that will help really settle our cancer patients close to their families at home. Yeah.
Well, we want to take a short breather, but before we do, Honorable Gladys Wanga has raised a very important point. She says we must address corruption. And according to the Ethics and Anti-Corruption Commission, Kenya loses 1/3 of its national budget to corruption. Now this year, the national budget was roughly 3.02 trillion Kenya shillings. 1/3 of this money is 1 trillion Kenya shillings. Now, from the numbers that I shared earlier, it costs roughly 1 million Kenya shillings to treat a cancer patient. 1 million Kenya shillings divided by 1 trillion, 10,000 cancer patients would get treatment, quality treatment, and accord them a dignified life. Let those numbers sink in. We take a short breather. When we come back, time for Social Watch.